This morning we'll be performing Kimberly-Clark's TransDiscal Biacuplasty at L4, L5. This is a procedure indicated for internal disc disruption and discogenic pain confirmed by provocation discography. The procedure works by ablating the ingrowth of nociceptors and nociceptive fibers, and also by theoretically remodeling collagen at the level of the procedure. To get started, we identify the operative level here at L4-5. We're going to tilt the fluoroscope in the cephalad direction so that we line up the end plate at L5, the superior end plate at L5. It's going to be about 28 degrees of tilt. We then will start off in the right side by rotating in the ipsilateral oblique direction so that the superior articular process at this level bisects the disc. The target is just ventral to the superior articular process at the midpoint of the disc. Once the target is identified, I typically anesthetize the skin, but also typically anesthetize deeper with a longer spinal needle, projecting the track that I'll be using with my introducer, my ultimate introducer needle. Once I place my introducer needle, I'm working to obtain a coaxial approach so that I don't have to make too many changes as I get deeper into the space. Once that coaxial approach is obtained, I keep moving the needle forward until I enter the disc. Typically, once you've entered the disc, a slightly different consistency is noted. Once I feel that I'm in the annulus of the disc, I obtain an AP view. And here you can see that I've entered just the outskirts of the annulus fibrosis. Under AP view, I typically advance somewhat further into the disc. And at this point, I would obtain a lateral view. The goal of the AP and lateral views is to ensure that in AP, that the needles are lateral to the mid-pedicular line, and that in a lateral view, the needle is at the junction of the ventral 2/3 and the posterior 1/3 of the disc space. You can see here that we've come across the disc somewhat, but haven't quite achieved the depth that we'd like to. So at this point, I would advance the needle further until I was approximately at the level where I was at the junction of the ventral 2/3 and the posterior 1/3. It's also important to remember that once the needle stylet is removed, that the actual probe itself will project somewhat further than the tip of the needle. At this point, we'd obtain an AP view. We're going to go back into a tilted position to ensure that we've achieved enough depth, and also to confirm that we remain lateral to the mid-pedicular line. And this is an optimal position for this procedure. You'd want to place the left-sided needle with a similar technique as the one used on the right side. Certainly there's no need to reinvent the wheel. You can use the same measurements and just reverse them to the other side to place the probes appropriately, or the needles appropriately. Again, you'd want to ensure a perpendicular coaxial technique to do this. Once you've got the needles in and you're comfortable with the position, and you take a picture that shows that the needles are superimposed, as they are in this picture, you'd remove the stylets and place the probes. Again, under lateral view, you want to ensure that the probes superimpose and that they're at the junction of the ventral 2/3 and the posterior 1/3 of the disc, as they are in this picture. Once you're comfortable with your view under lateral imaging and the positioning under lateral imaging, you would then once again return to AP imaging to ensure that the probes were placed appropriately. Again, at this point, you'd want to ensure that they weren't medial to the mid-pedicular line. It's also important to maintain a consistent degree of tilt to ensure that you're getting the same picture. And as you can see at this picture, the needles and the probes remain lateral to the mid-pedicular line in an appropriate position for this procedure. Once the probes are placed and their position is ensured, you would be able to commence with the TransDiscal procedure and the protocol. You'd want to ensure that the patient was awake, oriented, and alert to ensure that they could report any paresthesias during the procedure. Following the procedure, I remove the probes and the needles, ensuring that the probes are intact, and I have a brace placed on the patient while they're in the prone position. They then move on to the recovery room stretcher with the brace on, and I restrict hip flexion for several weeks following the procedure. We also have the patient go through a very regimented recovery and physical therapy protocol to ensure optimal healing time. This procedure, the TransDiscal Biacuplasty, again, is appropriate for patients with internal disc disruption and discogenic pain confirmed by provocation discography. Thank you for watching.